Hi, everybody. I am Monica Molenaar. I'm one of the co-founders of Alloy Women's Health. We are so glad to have you here to join us today to talk about navigating the tricky waters of treating your menopausal symptoms after breast cancer or potentially after a BRCA diagnosis. This is a topic that's near and dear to my heart, as I am BRCA positive. I have not had breast cancer myself, but I have been screened for the last 25 years for it. And so I have become somewhat of a subject matter, certainly interested party expert, as also starting this business, Alloy. And I'm here to moderate this discussion with one of our fantastic prescribing doctors, Dr. Corinne Menn, who is an OBGYN and also a breast cancer survivor herself. So extreme subject matter expert, as well as Dr. Avrum Bluming, a breast oncologist and one of the co-authors of a book called Estrogen Matters with Dr. Carol Tavris. That is a book that really helped actually launch Alloy in terms of the way that we're thinking about approaching this problem. And I know is a book that has really changed the way that the world is thinking about estrogen and hormones after breast cancer. So thank you both so much for joining us and for being here today. I'm going to turn it over to both of you to introduce yourselves and why this is also such a important topic for both of you. And then we have a whole bunch of questions for you, Dr. Bluming, about how do we get this information out to women in a way that's digestible and allows them to really feel good in their own skin after such a diagnosis. So, Dr. Menn, could you please talk to us a little bit about who you are and your experience?
Sure. So my name is Dr. Corinne Menn, and I'm a board certified OBGYN and a North American Menopause Society certified menopause practitioner. I'm also a 22-year breast cancer survivor. I was diagnosed when I was 28 years old during the second year of my OBGYN residency, just a few weeks after my mom died of ovarian cancer. Subsequently found out I do carry the BRCA2 gene mutation, and due to my cancer treatments, I went through menopause 3 times, due to side effects of treatment, and then finally having my ovaries removed, and found myself not really well educated on how to deal with the menopausal woman in general, but certainly not how to deal with menopause and breast cancer. And none of my doctors knew how to help me. So I struggled for years, and it wasn't until many years later that I found help. So super excited to be here. And Dr. Bluming's book and his research has changed my life professionally and personally. So grateful to have him here with us.
I'm delighted to be here. I'm a medical oncologist. I'm retired from active practice. My practice for over 40 years constituted about 60% of patients having breast cancer. I treated many women with breast cancer. I have followed what happens with breast cancer, and I know that today, newly diagnosed breast cancer carries about a 90% cure rate, and it's important that we keep that in mind throughout this discussion. When I treated premenopausal women with chemotherapy, and I treated many, in many cases, I induced precipitous menopause, women who had significant symptoms. I'm a male. My reaction to the women by and large was, well, there's a great chance we have cured your breast cancer, and I understand you have symptoms, but wasn't it worth it? And that was pretty close to the end of the discussion. My wife at age 48 came down with breast cancer. I treated her with chemotherapy. She was fine, and she started developing symptoms that many in our listening audience are familiar with: hot flushes, sleep disturbances, palpitations, genitourinary symptoms, painful urination, and she tolerated all of that without complaining to me about it until she started noticing that as she was reading a book, and she was and is a voracious reader, she would find about 2 minutes after reading a page, she didn't recall what she had read. And that was devastating. And she spoke to me about it. like Monica and Corinne, I became much more invested in what happens to women as they go through this transition, especially women with a history of breast cancer. And after extensive research of all available studies, I started my own study of hormone replacement therapy after successfully treated breast cancer. And that brought me into this arena as well. I wrote the book Estrogen Matters with Carol Tavris, a wonderful social psychologist who is an instructor with a sense of humor and a wit that can deliver information in a painless way that you retain.
So I just want to thank you so much. And I want to back up for one quick second, because I think I didn't introduce properly sort of also Alloy and what we're doing here. Alloy is a business that I started with a partner, Ann Fullenwider, came out of my own experience after having my ovaries removed. I went into menopause, and navigating just menopause generally is such a difficult thing to do. So, after 5 years of struggling, I started Alloy in order to help other women not have to go through the same pain that I did. And then once you deal with sort of the normal menopausal women, then of course there's a whole other can of worms after breast cancer. And so that is really why we're having this discussion at Alloy. We do have access to, we provide access to trained expert menopause physicians like Dr. Menn, as well as the prescription solutions that are available. And we do have several that are available for women who have had breast cancer, which we will also talk about. And this webinar will be recorded, and we'll put it on our YouTube channel with a whole bunch of resources as well, including a landing page that's in the chat, that we have put together with a lot of information. So we're really here to educate and inform and give women a platform to be able to make decisions for themselves or in shared decisions with their doctor. If you have questions, please put them in the Q&A, and we will sort of go through those questions as we go. But from here, Dr. Menn is going to start asking some questions, just go through some of the facts, and let's dive into it.
Okay, so yeah, let's get right into it. So let's just do a lot of important fast facts about, first, what are the benefits of estrogen therapy, hormone replacement therapy, or we often call it menopausal hormone therapy?
I assume that's directed to me.
Oh, yes.
Okay.
It's all directed to you.
Okay, that's fine. First, just to lay the groundwork, hormone therapy, menopausal hormone therapy, hormone replacement therapy is primarily estrogen, since a woman, as she goes through menopause, has a precipitous fall in circulating estrogen levels that result in symptoms. Men have a fall in testosterone levels when they reach a certain age, but it's a very gradual fall. With women, it's precipitous. So in order to treat the symptoms that result from that drop, estrogen is the primary treatment. What we found in the 1970s is that estrogen alone does increase the risk of uterine cancer. And we also found that if we add a second hormone called progesterone, that increased risk is neutralized. So that for women with a uterus, hormone therapy constitutes estrogen and progesterone, and a woman without a uterus, it is estrogen alone. What we now know about hormone therapy is, first, since we all want to live as well as possible, as long as possible, that is made possible with estrogen, so that women who take it have a median increase in longevity of about 3.5 years. Breast cancer is frightening women, but 7 times as many women die of heart disease than die of breast cancer. When I say that, what I'm usually told is, well, Old women die of breast cancer, and young women die of breast cancer, older women die of heart disease, and I'd rather die when I'm old than die when I'm young. And that's not true. That for every decade of a woman's life after age 40, the risk of dying of heart disease is greater than the risk of dying of breast cancer, and that difference increases with every succeeding decade. Hormone replacement therapy decreases the risk of atherosclerotic heart disease by 50%. About as many women in the United States die of problems related to hip fracture due to osteoporosis, another problem with menopause, and hormone replacement therapy is the single best preventive treatment for avoiding hip fracture. If there's one thing that women are more frightened of than breast cancer, it's cognitive decline, senility, Alzheimer's disease, and the only treatment we know in a preventive fashion is estrogen, which has been reported to decrease the risk of cognitive decline by 25 to 65%, depending upon which study you read. It also decreases the risk of diabetes. It decreases the risk of colon cancer. And perhaps most relevantly, it is the single best treatment for the menopausal symptoms that affect up to 75% of women, and that usually last a median of 7.5 years, longer for women of color. Nothing comes close to estrogen for decreasing those symptoms.
So we've got all these amazing benefits, both for symptom relief and for preventative healthcare concerns. So why is there so much misinformation and fear out there by the general public and also with physicians? Because most women come to me and their doctors don't know anything about it or are very against it or fearful.
We are a risk-averse species. We are concerned when we hear of something that causes a risk, and we avoid that something, even if doing a positive action is less risky than doing nothing. About 44% of menopausal women in the United States in the early part of this millennium, around 2000, were taking hormone replacement therapy. And in July of 2022, there was first a press release and then an article published in the Journal of the American Medical Association reporting the results of the Women's Health Initiative, claiming that hormone replacement therapy did many, many bad things. And we can get into those claims, but just about every one of those claims has been walked back. But because one of the claims was breast cancer, even though at that time, estrogen was not associated with any significant increased risk of breast cancer, that was the headline in the New York Times. And the rate of prescriptions for hormone replacement therapy fell from about 44% to less than 5%, where it remains today.
So much fear from a almost over 20-year-old study. And, are there any points, this could be a whole webinar itself, but any main points that you want to tell the viewers about that study, just so that they kind of have a basis going forward?
I will, but feel free to cut me off if I become.
I know, it's a can of worms.
Can of worms. So yeah, in a tiny nutshell.
Okay. First, the population that was treated had a median age of 63. Most women start hormones around 49 to 51, which is when the great majority of women go into menopause developing symptoms. And what we now know, and that the Women's Health Initiative investigators confirm, is women who start hormone therapy, estrogen or the combination, around the time of perimenopause have no increased risk of breast cancer. even women who are BRCA positive with abnormal BRCA mutations. We know that the benefits that I already elaborated are most prominent within 10 years of a woman's last menstrual period, so that would be the best time to start hormone replacement therapy.
So you mentioned BRCA mutation carriers. Let's just also lump in there women who have a higher risk of developing breast cancer due to, say, their family history, or maybe they have very dense fibrocystic breasts. Women are often told that raises their risk. They may have had some abnormal, they may have had biopsies that were found to be benign, but increase their risk. So can you just give some guidance about what the science tells us about those women versus the average woman and the risks of hormone therapy in terms of breast cancer?
Thank you for the way that question was phrased, Corinne. You talk about guidelines, and guidelines aren't commands. Guidelines are boundary recommendations that will work for a large percentage of patients. I'd like to stress that these aren't candies that we can give out to everybody who wants them. This should be a discussion with your healthcare practitioner. But the best guideline is the overwhelming majority of women would benefit from taking this treatment that we are discussing.
And as you mentioned, yeah, guidelines are simply put guidelines, but a lot of women are surprised, and I think doctors don't even realize that organizations like NAMS, like ACOG, have some very clear guidelines that even women who are BRCA positive, that the preponderance of evidence shows that hormone therapy doesn't further increase their risks of breast cancer.
That's true. Thank you for clarifying that. That's true for women with a family history of breast and/or ovarian cancer. That's true for BRCA positive women. And there are other genetic abnormalities that don't get as much publicity, but it seems to be true for them as well.
And then just quickly, so women understand, when we talk about hormones, there's systemic hormone therapy in like pills or patches, and we promote and endorse FDA approved versions of that, right? Not pellet therapy. But vaginal estrogen, it's local, it's not systemically absorbed. Can you just say a few words about that? And then let's talk about the black box warning.
Easily. And I can throw in the black box warning in the answer, which is after that first press conference and the JAMA article, the FDA put a black box warning on every product containing estrogen, and that includes transvaginal as well as oral or patch therapy, saying this preparation has been shown to increase the risk of cancers, breast cancer being implied, and it's certainly the one that got the most publicity. At the time the Women's Health Initiative was published, I mentioned there was no evidence that estrogen alone increased the risk of breast cancer. Now, after over 20 years of follow-up, what the Women's Health Initiative reports is that estrogen alone decreases by 23%, and it's a significant decrease, the risk of breast cancer development, and decreases by 40% the risk of death from breast cancer. The only issue that the Women's Health Initiative holds on to is they say the combination of estrogen and progesterone increases the risk of breast cancer development, not breast cancer death, and that is no longer felt to be valid by many academicians and scientists because when the Women's Health Initiative is corrected for age, the increased risk is no longer seen. When it's corrected for other modifying factors, the increased risk is no longer seen. And in fact, when you look at the Women's Health Initiative data, the increased risk that they talk about isn't really an increased risk. To go through that in detail, I think would be confusing on a podcast, but I have reviewed it in articles and we could get into that if you wish.
Sure.
I think given the number of questions that we have coming in about specifically different types of breast cancer and the types of breast cancer treatments, let's get into that.
We're going to jump into that now. And just to be clear, when we say vaginal estrogen is not for systemic symptoms. It's just treating vaginal symptoms. So let's get into breast cancer. So let's just explain to people estrogen receptor positive versus estrogen receptor negative. These are markers of individual breast cancers. So I'd love for you to comment on that. I'm just going to ask you the first question that I get all the time. Doctor, I am estrogen receptor positive. So that means they think that means that estrogen caused their breast cancer and it's feeding their breast cancer. So can you comment on receptor statuses and that belief that women have?
There are now 26 studies in the medical literature that I could find in languages that I can understand, and I reviewed all of those studies. Of those studies, of the 26 studies, 25 show no increased risk of recurrence of breast cancer among women who take hormone replacement therapy of any kind, and that is independent of whether they had estrogen receptor positive or estrogen receptor negative breast cancers. The one study that suggested an increased risk of recurrence, that reported an increased risk of recurrence, is a study that was done in Sweden called the HABITS study, Hormones After Breast Cancer, Is It Safe? That's an acronym. And that study reported an increased risk of contralateral or local breast cancer, not an increased risk of distant recurrence. There was no increased risk of death from breast cancer in that one study as well. That one study has several problems, the biggest problem being that study did not mandate baseline mammograms for women going into the study. If the only risk is a local recurrence or a recurrent or a cancer in the other breast, a baseline study mandating that it wasn't there before starting, you would think is important, and that wasn't done.
Yeah, big problem. So the studies that you're referencing, you wrote an article. Can you just speak to that in the Cancer Journal? And you really summarize it quite well in your book for people who really want to get into it. But I think it's really important for women to hear that sentence you said, that there are such a large number of studies and then reviews of those studies, correct?
Yes, there are 20 reviews. I said 26 articles, 20 review articles, none of them, with the exception of the HABIT study, which is a faulted study, show an increased risk of recurrence. 4 show a decreased risk of recurrence. But people hear the word breast cancer, it's a red flag. Both patients and physicians are frightened by that red flag. When you look at confirming evidence, you see that women who get pregnant after a diagnosis of breast cancer, which floods their bodies with estrogen, women who have in vitro fertilization, which further increases the risk of the level of estrogen in the body, have no increased risk of recurrence following a diagnosis of breast cancer. There's even an article that just came out of Harvard by Ann Partridge that reports a 6-year study where women who were on tamoxifen because they had estrogen receptor positive breast cancer had the ability, the permission to stop the tamoxifen for 2 years, allowing them to get pregnant, and 60% of the women did get pregnant, and they were followed then for 6 years, and these women had no evidence of an increased risk of recurrence.
Dr. Bluming, so to jump in, I'm monitoring the questions, and there are lots of questions from people who have had different types of breast cancer. So HER2 breast cancer, ER positive, ER negative. Is there a difference based on the type of breast cancer that you've had that would determine whether or not you would be counseled for or against HRT in menopause?
Before I can answer that question specifically, I have to explain that I'm a medical oncologist. Breast cancer has been a central passion of mine and one in which I specialized in. And I don't know what causes breast cancer. And I say that with both humility and arrogance. The humility is I really don't know, and the arrogance is nobody knows, and I know that as well. So that I have to look at data to be able to answer questions. Of the 26 studies, 19 studies looked specifically at estrogen receptor positive or progesterone receptor positive patients and compared them with women who had negative receptor breast cancer, and there was no difference in the results. No subcategory was found to have an increased risk of recurrence. HER2/neu data, amplification data, were not reported in the majority of those studies, but there doesn't appear to be any relationship between the genetic abnormality of HER2/neu amplification that we see and hormone action.
Speaking of just before we go further, estrogen receptor status, this idea that patients tell me I am estrogen receptor positive, hence estrogen caused my cancer. They really think that. Can you explain what estrogen receptor status actually means?
Sure. First, the majority of cells in the breast do not have an estrogen receptor on them. They are usually estrogen receptor negative in their baseline situation. Estrogen receptor is a molecule that is present on the surface of about 60% of diagnosed breast cancers. And that molecule allows estrogen to bind to the cell surface of those cells, and estrogen stimulates multiplication of those cells. Well, it's very easy to extrapolate saying, well, if it stimulates multiplication of those cells, doesn't that mean it can increase the risk of breast cancer? Well, I could understand that supposition, but the data don't support that. Does it increase the proliferation of cells already in the body, malignant cells? Well, it might, but the data don't show an increased risk of recurrence among women who take it, who had estrogen receptor positive cancer. And Tamoxifen, which was marketed as an estrogen receptor blocker, has supported the thought that estrogen stimulates breast cancer proliferation. Well, you have to know that when estrogen is compared to tamoxifen, women with breast cancer either got estrogen or got tamoxifen. It was high-dose estrogen back in the 1960s. Estrogen actually had better effect on the breast cancer than tamoxifen did.
So wait, so people understand you're saying is historically estrogen was used to treat breast cancer.
To prevent breast cancer among survivors from recurring.
Okay.
And it was better than tamoxifen. But it caused fluid retention and bloating. It was given in high dose, so it was stopped. Tamoxifen being an estrogen blocker, and it works in about 50% of estrogen receptor positive patients, it will shrink measurable breast cancer. But tamoxifen works in at least 10 other ways that we know, in addition to what it does with an estrogen receptor, and its method of action appears primarily due to these other activities. When women who get tamoxifen for treatment of measurable breast cancer start progressing in spite of the tamoxifen, giving them estrogen often causes the breast cancers to shrink, so that changing the environment in which breast cancer develops appears to be more important than specifically attacking the estrogen receptor.
Such an important message. Can you just explain to women the differences between tamoxifen and an aromatase inhibitor, and this idea that tamoxifen itself, when used alone, doesn't necessarily, it doesn't put you into menopause, and it doesn't lower your estrogen levels. Because there's this idea, I'm on tamoxifen, I'm going to have low estrogen levels. People don't really even understand how these drugs work.
I told you that tamoxifen was first marketed as an estrogen receptor blocker. And it was thought that it would not work on premenopausal women, since premenopausal women have elevated levels of estrogen in the circulation. And when you give tamoxifen to a premenopausal woman, the level of circulating estrogen goes up by up to 5-fold. So it was marketed primarily for postmenopausal women, saying that the competitive inhibition of the estrogen receptor with tamoxifen would be best in premenopausal women. Surprise, it's actually more effective, best in postmenopausal women. It's more effective in premenopausal women, and now it is the treatment of choice for premenopausal women, even though it dramatically elevates the circulating estrogen level.
Dr. Bluming, I just asked you, women who are premenopausal who take tamoxifen, I know you've talked to me about the SOFT trial and understanding that. Do these women have to have, ovarian suppression when they're on tamoxifen if they're premenopausal? Does the data tell us that lowering their estrogen levels makes tamoxifen work any better?
Let me first answer your question about what aromatase inhibitors do. Testosterone is produced in both men and women. Women have higher levels of testosterone than they have of estrogen, even adult women. And the way estrogen is produced is there is an enzyme called aromatase, which converts circulating testosterone into estrogen. So that when a woman, especially a postmenopausal woman, is giving an inhibitor of this enzyme, testosterone is no longer converted to estrogen and the estrogen levels fall. And aromatase inhibitors, which is the treatment of choice in postmenopausal women, does seem to have a small advantage over tamoxifen in the treatment of postmenopausal women. How small an advantage? They might be 2 to maybe 6% more effective. That is very small. That means out of 100 women, somewhere between 2 and 6 would be better off taking an aromatase inhibitor than taking tamoxifen. Because aromatase does lower the level of estrogen, it was thought, as you point out, that giving an aromatase inhibitor to a woman who has suppressed ovarian function might improve the ability of tamoxifen to treat measurable breast cancer. And it does by about 2 to 6%. That's all. Yeah. And Craig Jordan, the man who developed tamoxifen, has said, in premenopausal women who get tamoxifen, estrogen levels go up dramatically with no negative effect on the ability of tamoxifen to control the breast cancer. Why would it be harmful to give low levels of replacement estrogen to women on tamoxifen? That would seem to make sense. I know of no study that has looked at that at this point, but that certainly sounds reasonable to me.
Sounds reasonable to me too. It often starts to not make sense. When I was on tamoxifen before I had my ovaries removed, they allowed me to have my periods. I had high estrogen levels for a period of time. No one thought anything of it. And then when I elected to take my ovaries out because of a BRCA2, suddenly, and I was suffering terribly from menopausal symptoms, suddenly it was unacceptable for me to even consider a teardrop of estrogen versus the ocean of estrogen that I had been in for a number of years while on tamoxifen. And it seemed like it was very black and white, and there was no discussion about, treating my menopausal symptoms with a little bit of estrogen. So
why are aromatase inhibitors used in the first place? Like, when would you use an aromatase and choose an aromatase inhibitor?
Well, when we're treating breast cancer, we want to give a woman the very best chance of never having it come back. And in a postmenopausal woman, even though 2 to 6% improvement over tamoxifen doesn't sound like a lot. For those 6 women out of 100, it could be life-saving. So of course, use it, but don't abandon tamoxifen as a possible alternative, depending upon the trade-offs you have to use. And Corinne, as you're well aware, I always speak conditionally. Nothing is my last word about anything, and I constantly review data, but I'm going to make a categorical announcement now in answer to an earlier question, which is, I know of no evidence that transvaginal estrogen compromises anybody's health while it improves genitourinary symptoms.
Thank you, because it's so important. You know, I spoke recently to an audience of over 400 young breast cancer survivors, many who were dealing with severe genitourinary syndrome and menopause changes, making, you know, their personal lives, their relationships, their sexual relationships, their urinary health really difficult. And a lot of them were really suffering. And it was like mind-blowing for them to hear the statement that you just made. I said the same statement to them. No, their oncologists don't discuss vaginal estrogen use with them. And if they do, it's an incredible amount of misinformation and fear. Now, I know that ASCO has guidelines on this, as does NAMS and others. How come in the oncology community, we see such an incredible resistance to even vaginal estrogen?
I don't know the answer to that. I can't explain it, and I certainly can't defend it.
So, and getting back to, in terms of speaking with oncologists, you mentioned, you know, adjuvant endocrine therapy, many women, and I see there's a trend over the past decade or so of escalating endocrine therapy, of this idea of more suppression of hormones is better, leaving women with a ton of collateral damage. And I often tell women it's okay to speak to your oncologist about finding a middle ground. And then oncologists by training should be pretty well versed in explaining risk versus benefits. They do it all the time for chemotherapy. So do you have some like maybe talking points to tell the audience about, you know, talking to your endocrine or your oncologist about managing your endocrine therapy, and that it's okay to go, maybe the ideal is 10 years of an aromatase inhibitor for some women, but it's okay to do a mixed picture of some tamoxifen, some aromatase inhibitor, changing things up if you're not tolerating it. So can you just speak to that?
I think women have to become educated to some degree to be able to have this interactive conversation with their oncologist. Eric Weiner, who's the current president of the American Society of Clinical Oncology, at the annual meeting that just concluded in Chicago, gave a talk called Physician-Patient Cooperation. What a wonderful idea. So when a patient asks a question, she shouldn't allow a physician to dismiss the question with statements like, I don't want to give you a pill that will kill you. No, if you do that, you have to seek a different physician. That's wrong. Benefit and risk must be balanced, and the patient must have a strong voice in championing what she wants. Remember, I started by saying, we all want to live as well as possible, as long as possible. If, as we pointed out, estrogen not only improves longevity, and by the way, that's true among breast cancer survivors as well, it certainly improves quality of life. Why shouldn't that be a topic of discussion? And if there is a risk, doctor, I need you to quantify the risk for me. I need you to be open to my challenging that risk with data that I can produce. And then let's have an open discussion.
Amazing.
Crazy people say can't, when we use the word can't, women can't have this, or you're not a candidate without any discussion or
And I
input.
just, absolutely. I just want to say, you know, when we're talking about hormone therapy after breast cancer, you always state this, a woman has to be treated for her primary breast cancer, you know, that's a very important point. It's very important that they, you know, and then they make that decision with their doctor about what's the best treatment for them. So I know you mentioned, so a woman is finishing her primary treatment. It might include tamoxifen, aromatase inhibitor. and she can talk to her doctor whether she's going to manage symptoms hormonally or non-hormonally, different options. But once she's coming to the end of her aromatase inhibitor, and she's done her 5 years or 10 years or whatever, who is the ideal person to have the discussion of like, okay, I'm looking forward for my future and, you know, hormone therapy as an option? Who's the best person, best candidate? And what would be your kind of concluding advice to that woman, kind of before we open it up to questions?
Well, the responsible person is going to be the oncologist. The OBGYN physician, the internist, is probably not going to give advice along those lines against advice that the oncologist gives. So she would have to go to the oncologist and discuss it. But it's important to be aware that we started this discussion by saying that the data that estrogen either causes or stimulates breast cancer growth is not proven, and as far as cause is concerned, is no longer considered valid, and the data don't support that. So that the thought that even early breast cancer should be treated with tamoxifen for 5 or 10 years has to be challenged by the patient saying to the doctor, okay, doctor, I had my lump taken out with or without radiotherapy, or I had my breast taken off, depending upon how the primary treatment was done. You are now advising me to take tamoxifen or an aromatase inhibitor. Doctor, I need you to tell me, what is my risk of the cancer coming back if I take nothing? What is my risk of the cancer coming back if I follow your advice and take one of these drugs for 5 or 10 years? And doctor, what do you think about the new trial of tamoxifen, not 20 milligrams a day for 5 or 10 years, but tamoxifen at 5 milligrams a day for 3 years, which at 6 years currently appears to be equivalent to tamoxifen for 5 years. What is your opinion of that, given my current situation? And that discussion is mandatory if we're going to start changing physicians' approaches to this.
And you often talk about informed consent, right? So if a patient is having a hard time trying to get quote unquote permission, which I hate that term, from their oncologist, but I think it's something that they can talk to them about, like, I've been informed, and, you know, can you work with me? Because this is something I'd like to consider to treat my symptoms and my long-term health, right?
Doctor, there may be 2 reasons why you are refusing to give me hormones. One is you are looking out for my best interest, and I really appreciate that, but we need the open discussion so that I understand what you see as my best interest. The other is the possibility that I may have a recurrence, and you're looking out for your best interest, and you don't want me to sue you for this. And if the second is entering into your thoughts at all, I am willing to sign an informed consent form saying I understand this. And by the way, the article I wrote in the Cancer Journal has in its appendix an informed consent form that can be used as a prototype, so that, doctor, I will do whatever I can to relieve you of legal culpability while we discuss what is best for my future.
On that Cancer Journal note, one of the questions was, how do I get access to it? Because it's behind a paywall, but we will make that available, or Dr. Bluming has copies that he can send, so we can, we will have notes for how you can get that.
Yeah, reach out to us. We'll help you get it. And I think before we're going to jump into questions right now, but I just do want to say that this entire discussion, if you want to understand it more, Dr. Bluming's book is amazing, and it's a really very patient-friendly, doctor-friendly, book, and can really help you really digest all that we talked about today. So highly recommend you read it, but I also love listening to it, because I loved when you read parts of it, Dr. Bluming. It really sunk in well with me when I heard your voice in this book. So thank you. So Monica, do you want to turn it
So
over to questions and
some
see
of the
how we can get in?
questions, yeah, we have a lot of questions, so we'll try and get through as many as we can. I'm gonna, for example, if you've had someone had stage 1 breast cancer 18 years ago, this year diagnosed with DCIS in the same breast at age 60. She was on HRT, but told to come off of it. Is it sensible to go back on now that she's had surgery and the DCIS removed?
Is this her second cancer, or the DCIS was diagnosed after 18 years of treatment?
Yeah.
Of HRT, first diagnosis of cancer. Okay, first, let me say again, we're not giving specific advice to patients over this. We're just giving information that can be used. If a woman is 10 years post her last menstrual period, and it sounds like this woman is not, but if she is, then the benefits vis-a-vis heart disease, osteoporosis, cognitive decline are valid, and it's worth discussing. Going back on hormone replacement therapy after a diagnosis of very early breast cancer is not out of the question. I just stated that of the 26 studies in the literature, just about all of them, except for the one we challenge, show that it doesn't increase the risk of recurrence, even for estrogen receptor positive breast cancer. So there's no reason why she shouldn't bring this up with her physician and say, how can you help me?
Yeah. And actually, does dose matter in terms of safety? A lot of people have asked that as well. Is there a minimum dose that I should take to prevent? Is there a maximum dose that I should take for safety reasons? I mean, there are general standard doses, but I think within that.
One of the things that physicians and patients are told is, well, if you must take hormones, take the lowest dose for the shortest period of time. There are no data in the medical literature supporting that statement. That's a timid statement based on people saying, well, I really don't have data saying it's bad, but I'm just afraid. Well, that's not a way to make a medical judgment. There are standard replacement doses, depending upon the preparation you take, whether it's a pill or a patch, and those doses, and Corinne, being an OBGYN, is more of an expert on that than I am, those will work for about 70% of postmenopausal women. Somebody who tells you, well, I'm going to analyze your saliva or your hair for your level of hormones in your tissues, and I will customize a dose for you, run away from that office.
Yep.
The standard dose works for the majority of women. Depending upon what symptoms a woman has, how well her symptoms are controlled by this approach may require some changes in the dosing, which can be done by a responsible OBGYN physician.
Yeah. What about young women with ER, PR positive breast cancer in their 30s? How would you counsel a woman that young in terms of hormone therapy, or therapy in general, and then therapy after their primary treatment of breast cancer?
Okay, well, as you first point out, breast cancer is something we all take very seriously. Even though there's a 90% cure rate, that means it's been approached responsibly, and we have been able to cure 90+% patients. So that regardless whether it's ER positive or HER2 amplified, the treatment will depend on the size of the tumor, whether or not lymph nodes are involved, whether there's tumor anywhere else, and that's important to take into consideration. But what I told you is, after therapy is completed, a discussion about the advisability of hormone replacement therapy, the benefits and the risks, is a very worthwhile discussion to have.
Monica, I just want to jump in and say to the listeners that I think it's important for women while they're on treatment, that at any time they really should talk to their doctor about the use of vaginal estrogen. I think that's super important, and understand that that's sometimes like two separate conversations, right? So that's very, very easy to kind of approve and okay for a woman who's dealing with the side effects of that. And I also just want to jump in and to say that there are non-hormonal options to treat your vasomotor symptoms, your hot flashes, your night sweats, your insomnia. And, Dr. Bluming will, I'm sure, agree that those non-hormonal options do not have all of the preventative healthcare benefits on your bones, your brains, your heart. But that being said, it's still better to not be woken up all night and feel terrible and not sleep and all of that. So those non-hormonal options are valid, particularly when you're in the midst of being on an aromatase inhibitor. Do you want to add anything to that idea, Dr. Bluming?
Yes, one thing. I'm put off by the name hot flashes. That was probably developed by a man. A woman who experiences a heat that starts either in her chest or her skull that spreads to her face, turns her face red, causes her to perspire, spreads throughout her body, and lasts for upwards of 2 minutes is not a flash, that's a flush. And it's easy to dismiss a flash. When you're experiencing it, it's much worse than that.
Oh, yeah. That's not good.
Do you think that there's a difference in terms of safety or effectiveness between conjugated equine estrogens, so that's Premarin, versus FDA-approved bioidentical estradiol and progesterone, and progestin versus progesterone, as we're having this conversation?
Well, as far as estrogen is concerned, the bottom line is no. As long as it is FDA approved, compounded bioidentical estrogens are currently exempt from FDA approval. And when looked at, they contain varying concentrations of hormones. That makes me uncomfortable, and I don't know of any responsible organization that suggests that those be used. In terms of progesterone, there are subtle differences that are being studied right now. I can tell you that micronized progesterone is currently felt to be the safest form of progesterone, but we're constantly looking at those data to see if that changes.
And Monica, I just want to share, because everyone always wants to know, I did not take hormone therapy for many years. I completed my Tamoxifen therapy like a good girl. And I had my ovaries removed, and I dealt with my symptoms with non-hormonal options. And now, after many years, in conjunction with my oncologist, after learning so much from this amazing man, and understanding the science, I am on hormone therapy. I use a transdermal low-dose estradiol patch, and I take progesterone, and I use vaginal estrogen. And I'm not saying what I do applies to anybody else, but I think it's good for women to hear that, yeah, I'm a doctor, I understand the science, and I've chosen this for myself. And so, and I know, Monica, you had your ovaries removed because of being a BRCA carrier, and you are comfortable taking hormone therapy yourself, right?
I am. I had my surgery done at Sloan Kettering. I also was sent out the door without a prescription for hormone therapy. I didn't sleep through the night for 6 months. I gained 25 pounds. I was generally miserable and a total bitch until the first night I started taking menopausal hormone treatment. I slept through the night, and the rest is kind of history. I was given a first prescription for compounded. I've literally tried everything. I've used pellets. I've had so much testosterone from pellets that it was concerning, but I stopped that. I mean, I really went on a journey for 5 years, and now, thankfully, through Dr. Bluming, through my relationship with you, Dr. Menn, and Dr. Malone, who's our chief medical advisor at Alloy, and just really being immersed in this science and data day in and day out for the last 5 years, I feel super confident and happy about the choices that I've made.
Well, I never went through those symptoms, but my wife did, who's the single most important person in my life. And she was on hormones for 30 years. The other very important person in my life is my daughter, who also had breast cancer and who's also been on hormones now for close to 8 years. So that the three of us have very personal involvements in this. That doesn't prevent us from looking as objectively as we can at the data, but clearly there is strong motivation here to stay up to date and be sure that any advice we give is the best data available.
Yeah. I think we have time for like 2 more questions. One, since we're talking about so much about vaginal estrogen, one question is, my medical oncologist said no vaginal estrogen, but DHEA was okay. We haven't really talked about DHEA. She said she's read conflicting info on DHEA. Do you have any thoughts on that?
Dihydroepiandrosterone is a steroid hormone that shares many chemical characteristics with estrogen and testosterone. The problem I have with that statement is, having said the only categorical statement I made all during this conference, that I see no data saying that vaginal estrogen, which is the best approach for local treatment of those symptoms, is the best. Why not use vaginal estrogen? And the data on DHEA is nowhere near as extensive as the data we have on vaginal or transvaginal estrogen.
And I may just point out to the person that the oncologist's own society, ASCO, they actually have a statement that if your symptoms are bothering you and not relieved by vaginal moisturizers, which they probably won't be, that vaginal estrogen is acceptable. And maybe they're also referring to intrarosa, which is not a compounded DHEA, but the reality is intrarosa works by being converted to estrogen in the cell. So it's estrogen, basically. So, and I just have a quick question for Dr. Bluming, that I think there's a lot of probably younger survivors here. And then I think one question we don't talk about is that when you have premature surgical menopause, that in itself, forget the breast cancer treatments, that in itself raises your risk for cardiac disease, dementia, correct?
And early death.
And early death. So I think we have to balance that risks of our very early premature menopause with the rare risk of breast cancer death, right? Because we have it worse being younger, correct?
Absolutely.
I think we're at time, which is so sad because we have a million questions. So we're going to, one, take all these questions and try and create or write answers. We have a new landing page with a lot of information about treatments for menopause after breast cancer that Alloy can provide, or that you should just know about. So that that link is in the chat. We will have the recording for this video up on Alloy's YouTube channel by Friday, and we also will have a transcript as a blog post on our site. So we will continue to get this information out. If we're lucky enough, we might get Dr. Bluming back for yet another webinar one of these days, if he's not too sick of us by now. But we will work through these questions and make sure that everybody gets the answers, because it is so important for women to
Just the opposite, Monica. I love your enthusiasm and Corinne's enthusiasm and your commitment to data, which is spectacular. And just speaking of data, the book Estrogen Matters is written the way a medical paper would be written, heavily referenced, so that if you bring it to the attention of your physician and the physician says, this is a doctor in Southern California, you know what they say about people in Southern California, and you want me to take his word against what I think is right, show him the references and say, doctor, please read the references and come back to me with your version of what the data really show.
Well, I want to make one correction, though. It is definitely referenced and written in the way credibly like a scientific paper, but it's written in language that people who are not scientists, who are not doctors, can really understand. That's one of the things that I think is so powerful and beautiful about your book, is that it's actually written for women to be able to make use of this information in a way that is empowering and not scary or hard to understand. So thank you so much for your work in this, pioneering in this space, Dr. Bluming, and you, Dr. Menn, of course, for being one of our daily shoulders that we lean on, just, rock at Alloy, and a great prescriber. So for women who do want to have a consult, for example, with Dr. Menn or other prescribers, and ask questions directly to doctors, we do have that available. That service is available as well. So there's a discount code that is in the chat for anybody who would like to come to Alloy and see what we have for you. We have not only products like hormone replacement therapy, paroxetine, which Dr. Menn mentioned is a low-dose SSRI that's FDA approved for treating hot flashes, but we have also recently introduced vaginal topical Viagra for women. So if you want to actually increase your pleasure, your sexual pleasure, and improve your sort of just feeling down there, clitoris, vaginal, that's super helpful. And we have an estrogen-based face cream that also is a low dose and only topically absorbed and safe for breast cancer survivors as well. So we have lots of things for you available, and we are excited to have you along for all this information. Thank you so much.
Thank you so much for having us.
Absolutely.